Assalamu alaikum. Beta, today is our last lecture of the female genital tract, and today we study the some lesions of the placenta and fallopian tubes. So, today our topic is the lesions of the placenta and fallopian tubes. First of all, what is the placenta? Normal structure. As you know, it is the connecting organ, the connecting structure between the mother and the fetus. It is described disc-like organ है, 15 to 16 सेंटीमीटर डायमीटर है, 2 to 4 सेंटीमीटर थिक है, वेट जो है इसका तकरीबन 400 to 600 ग्राम है और 1/6 वेट ऑफ न्यू जब वो होगा तो उसका तकरीबन 1/6 इसका वेट होगा प्लासेंटा. Umbilical cord is about 50 centimeter long and contain two umbilical arteries, one umbilical vein attached at the fetal surface. Placenta is derived from both maternal and fetal tissue, as you know. Maternal portion has irregular grooves divided into cotyledons, which are composed of sheets of decidua bacillus. As you know, the decidua is the modified mucosal membrane of the endometrium, which is present during the pregnancy, and this decidua is prepared for the pregnancy and for the implantation. Fetal portion of the placenta is composed of the numerous functional unit called chorionic line and comprise major part of placenta at term. As you know, villous pores are covered by inner layer of cytotrophoblast and outer layer of syncytial trophoblast. Basement membrane separating fetal capillaries in the villous core and trophoblast form zone where nutrient and metabolite are transported between mother and fetus. The other name for this junction is the Vasculosyncitial membrane. It is known as the placental barrier. So something can transfer from the mother to the fetus, but not all the things, all the medicine, all the nutrients cannot across this barrier. Placenta secrete a number of hormones and enzymes into maternal blood. These include human chorionic gonadotropin hormone, human placental lactogen, chorionic thyrotropin, adenocorticotropin hormone. As you know, the human chorionic gonadotropin is the very much important for the pregnancy, and human placental lactogen and chorionic thyrotropin, the function is like the thyroid stimulating hormone. So as we see that during pregnancy, there is a increased thyroid level, T3, T4 is due to this hormone, chorionic thyrotropin, and adenocorticotropin act as a stimulate the adrenal cortex. So these hormones are mostly secreted by the placenta. Normally, when placenta is present, secrete these hormones. You can see here the structure of the placenta. Placental arteries, placental vein, myometrium, and the decidua, placental septum, cytotrophoblast, syncytial trophoblast, cotyledons are present, umbilical vein, intravillous spaces, chorion and amnion, chorionic amniotic membrane है. All this is the structure, half structure of this the placenta structure. Now, after the structure, placental infection and inflammation. Infection may reach the placenta by two paths ascending through the birth canal, hematogenous transplacental state. As you know, it is present in the uterus, so bacteria and are associated with premature rupture of the fetal membrane. Sometimes, as you know, the fetal membrane are ruptured at the term during the labor, but sometimes there may be due to certain reason, there may be a premature rupture of the fetal membrane. So when fetal membrane is not present, there is the chances of ascending of the different bacteria to reach to the placenta and causes the placental infection. As you know, the nature provides a protection against the infection, but when this is disturbed, the membrane is ruptured, so the bacteria reach to the placenta. On microscopic examination, chorioamnion shows neutrophilic infiltrate. As you know, neutrophil show the infection associated with edema and congestion. Acute, इसका क्या नाम है? Acute chorioamnionitis. Infection spread and involves the umbilical cord, placental villi, resulting in acute vasculitis of the cord. The name of this vasculitis of cord is sinusitis. Ascending infections are caused by the mycoplasma, candida, and other bacteria of the vaginal flora. जो normal vaginal flora में स्टेप्टो, स्टेफलो प्रेजेंट होते हैं वो, या इकोलाई, स्टेरिशिया कोलाई है, या इंटेरोबैक्टर, ऑल दीज कैन लीड टू द इन्फेक्शन. वैसे तो जब वो प्रोटेक्ट थे, लेकिन जब मेम्ब्रेन रप्चर हो गए, these bacteria can reach to the placenta and causes the placental infection and involve all the structure of the placenta which are present in the placenta. The second cause is the hematogenous. Hematogenous spread of bacteria and other organisms. तो दो रूट हो गए, एक तो असेंडिंग हो गया थ्रू दी बर्थ कैनाल, एंड सेकंड हेमेटोजेनस थ्रू द blood reaches the placenta. On microscopic examination, structures frequently affected are placental villi, और इस कंडीशन को कहेंगे villitis. The common conditions हैं which lead to the hematogenous infection of the placenta are the syphilis, tuberculosis, listeriosis, toxoplasmosis, and various viruses like the rubella, cytomegalovirus, herpes simplex. और इसको ये these are the viruses. There's a combination and the complex is called the torch. Torch में क्या होगा? Toxoplasmosis है, rubella है, cytomegalo and herpes simplex. There is a complex of these 4-5 viruses, toxoplasmosis, rubella, cytomegalo, and herpes simplex. And when this infection is occurred and it involves the placenta, it causes the congenital anomalies in the fetus, mostly the cardiac involvement, and also it lead to the premature death or maybe lead to the neonatal death. So this is very dangerous. Transplacental infection can affect the fetus. As I have told you, this is very dangerous and can affect the fetus. It can lead to the congenital anomalies and can lead to the death of the fetus in utero. So it is the placental infection. After this placental infection, the most important is the high-density deformed mole. High-density deformed mole means drops of water. Why? Because they look like clear, like the drops of the water. So the name is given the drop of water. And mole means shapeless mark. There is no complete, there is no clear picture or clear shape of these moles. So the name is given high-density deformed mole. It is defined as an abnormal placenta characterized by enlarged edematous and hydropic by water-like change of the chorionic villi, which become vesicular. Variable amount of trophoblastic proliferation. Incidence is high in teenager in older women. It is written that below 20 years and after 40 years is common. Incidence in Asia and Central America is 10 times higher than in US. तो ज़्यादातर ये भी जो कंडीशन है थर्ड वर्ल्ड कंट्रीज में, डेवलपिंग कंट्रीज में ज़्यादा है एज कम्पेयर टू द डेवलप्ड कंट्रीज. इंसिडेंस हाई इन पुअर क्लास. Hydratity deformed mole may be non-invasive or invasive. यानी कि it is divided into two main categories, invasive and non-invasive. Two types of non-invasive moles are distinguished, complete and partial. There, the exact etiology, exact cause of this hydratity deformed mole is not written, but certain speculation is present that they may be occurred due to the anomalies of the uterus, maybe due to the different defect of the ova, and maybe due to the certain deficiency of the nutrient, like the protein deficiency, folic acid deficiency, can lead to the not the exactly, not the exact mark, but it is speculated due to the certain deficiency of the different nutrient. There may be a hydratity deformed mole. Now here you can see the uterus is filled with these trap-like structure, clear fruit-like moles. This is the molar pregnancy. And here you can see here the uterus is covered with the trap-like structure, clear fruit containing granules. This is the picture of hydrately deformed mole. Now, as I have told you, there are two types, non-invasive and invasive. And non-invasive is again divided into two, complete and partial. So now we see what is the difference between these two. Complete, the other name of the complete is the classic mode, derived from androgenesis and has 46XX or rarely 46XY chromosomal pattern. Complete mode has relationship to the choriocarcinoma. There is a chances of the choriocarcinoma is more in complete mode as compared to the पार्शियल में तो ज्यादातर इसका पैटर्न कौन सा होता है 46XX 46XY कभी भी 46YY बहुत ही रेयरली देखा गया है ज्यादातर 46XX या 46XY होता है और चांसेस कोरियोकार्सिनोमा के कंप्लीट मोड में ज्यादा है एज कम्पेयर टू द पार्शियल मोड पार्शियल मोड जो है वो मोस्टली ट्रिप्लॉइड 69XXY 69 ट्रिपल एक्स हो सकता है एंड रेयरली टेट्राप्लॉइड यानी 92 ट्रिपल XY वो बहुत कम होता है ज्यादातर जो है ट्रिप्लॉइड होता है रेयरली डेवलप इनटू कोरियोकार्सिनोमा कंडीशन अपीयर दिस कंडीशन यानी कि मोस्टली कंडीशन अपीयर इन 4th to 5th month of gestation और जो कॉमन फीचर्स वो है कैरेक्टराइज्ड बाय इंक्रीज इन यूट्राइन साइज vaginal bleeding, history of passage of grape-like masses per vaginum. As you see in the picture, the uterus is filled with this grape-like structure. So this lead to the not only the vaginal bleeding, also the grape-like structure is passing through the vagina. 1% of women develop it again in subsequent pregnancy. So इसकी वजह से there are the chances of if one pregnancy is present with the mole, there may be the chances of this molar pregnancy in the next when she expect next time there's the chances of molar pregnancy again there. Single most significant investigation is the serial determination of villitis यानी कि human chorionic gonadotrophic hormone की estimation इसको डिटेक्ट करना बहुत जरूरी है which is elevated more in both blood and urine as compared with the level in normal pregnancy. Normal pregnancy से ज़्यादा जो है there is a more increase in the β-hCG level in molar pregnancy. अगर हम normal pregnancy से compare करें तो normal pregnancy में भी increase होते हैं. There may be increase level of the β-hCG, but its level is more in molar as compared to the normal pregnancy. Other जो tool है to detect this molar pregnancy is the ultrasound. Ultrasound is the most important tool, most important investigation to see this molar pregnancy और इसमें हमें कैसा नजर आएगा हमें नजर आएगा स्नो स्टोम अपीयरेंस जैसे कि बर्फानी तूफान आ रहा है स्नो स्टोम अपीयरेंस और अल्ट्रासाउंड 10% of patients with complete mole develop into invasive mole and 2.5% into choriocarcinoma. तो ज्यादातर जो कंप्लीट मोल है वही कोरियोकार्सिनोमा में डेवलप होते हैं और इन्वेजिव मोल में भी होते हैं इसी तरीके से पार्शियल मोल इन्वेजिव में तो चेंज हो सकते हैं लेकिन लेस चांसेस हैं कि वो कोरियोकार्सिनोमा में डेवलप हो ज्यादातर मोस्ट ऑफ द टाइम कंप्लीट मोल इज चेंज इनटू द इन्वेजिव and choriocarcinoma as compared to the partial mole. अच्छा पैथोलॉजिकल फीचर जो है वो नॉन इन्वेजिव एंड इन्वेजिव के डिफरेंट अच्छा अब जो है नॉन इन्वेजिव मैंने बताया कि दो है कंप्लीट और पार्शियल तो कंप्लीट में क्या है uterus is enlarged and filled with grape-like vesicles up to 3 centimeter in diameter. Vesicle contain clear vertices. वही जो मैंने बताया. Rarely macerated fetus may be found. ज़्यादातर जो है fetus नहीं होता, लेकिन rarely बिल्कुल बहुत कम chances है 0.00 के fetus present हो. वरना only the uterus is filled with these vesicles or these fluid-filled granules. Microscopically, uterus is large, rounded, edematous, and cellular villi due to hydropic degeneration forming central cistern. Decreased vascularity of the villous stroma, trophoblastic proliferation in the form of masses and sheets of both cyto and syncytial trophoblasts, generally circumferential around the villi. तो ये इसमें क्या होगा, यूट्रस जो है वो ज्यादा इनलार्ज होगी एज कम्पेयर टू द पार्शियल मोड, और इसमें जो है वो सारे के सारे जो है वो वेसिकल्स में चेंज हो जाएंगे एज कम्पेयर टू द पार्शियल मोड। अब ये आप देख सकते हैं पैथोजेनेसिस में क्या है, when the empty ovum which lost their DNA, which lost their nucleus is fertilized by one sperm, or which reduplicate, or they are fertilized by two sperm. So there is no maternal part, only the paternal part is present. So it can change into the 46XX, 46XX and 46XX, या यहाँ पर मिस्टेक है 46XY, सेल डुप्लीकेशन होगी। तो इसमें कोई पैटर्नल पार्ट नहीं होगा, maternal part नहीं होगा, only paternal part होगा। ये complete मोल है, only the uterus is filled with mold, there is no fetus is present in this condition, only the complete mold में कोई fetus present नहीं होता, और ज्यादातर जो है वो the uterus is filled with molds which contain fluid filled spaces। अब इसकी हम पिक्चर देखते हैं, अगेन आगे देखते हैं, ये देखते हैं इसमें जो है वो सारे के सारे जो है वो जो है आपको दिख रहे हैं साइटोट्रोफोब्लास्ट की जो लेयर्स हैं वो सब फ्लूइड फिल्ड स्पेसेस हैं, और सब एक जैसे आपको नजर आ रहे हैं। देयर इज नो डिफरेंशिएटेड और देयर इज नो अदर स्ट्रक्चर प्रेजेंट इन दिस। दिस इज द पिक्चर, हिस्टोलॉजिकल पिक्चर, माइक्रोस्कोपिक पिक्चर ऑफ कंप्लीट मोल्ड। ये देख सकते हैं आप, द यूट्रस इज फिल्ड विद मोल्ड्स, only they contain the molds, there is no other structure, there is no part of the fetus is there. Now the second is the, as you know, the non-invasive is again dividing two, as I have told you, the complete and partial। तो complete तो हमारा complete हो गया, अब ये partial, grossly uterus is generally small। अगर हम compare करें with the complete, तो uterus is generally smaller than expected and contains some cystic villi, while part of the placenta appear normal. So the part of the placenta is appear cystic, but part of the placenta is appear normal. A fetus with multiple malformations, congenital anomalies is present. इसमें जो है partial में fetus present होता है। अच्छा, microscopically some of the villi show edematous chain, while other are normal or even fibrotic। उसमें सारे के सारे villi इन्वॉल्व होते हैं। पार्शियल में सम villi show edematous chain, while other are normal और इवन फाइब्रोटिक, बिल्कुल सुकड़ जाते हैं, श्रिंक भी हो सकते हैं। उसमें कंप्लीट में सारे के सारे villi जो है एडिमेटस होते हैं, हाइपोप्लास्टिक होते हैं। इसके अंदर कुछ जो है वो हाइपोप्लास्टिक होते हैं और कुछ नॉर्मल साइज के होते हैं और कुछ फाइब्रोटिक भी हो सकते हैं। ट्रोफोब्लास्टिक प्रोलिफरेशन इज स्लाइट एंड फोकल। तो इसमें जो प्रोलिफरेशन है वो कम है एज कम्पेयर टू द कंप्लीट मोड। अब देखें आप, इसकी पैथोजेनेसिस क्या है, when a normal ovum, उसमें क्या था empty ovum, इसमें normal ovum is fertilized by the two sperm or one sperm which undergo reduplication। तो इसमें क्या होगा, जो है वो reduplicate हो गए, तो 69 XXY, 69 XXY, 69 XXY, या टेट्राप्लॉइड भी हो सकता है, 92 भी हो सकता है, लेकिन ज्यादातर ट्रिप्लॉइड होता है। तो ये इसकी पैथोजेनेसिस है, when a normal ovum is fertilized by two sperm or one sperm which undergo reduplication, या जिसके क्रोमोसोम डबल हो जाए। तो ये है पैथोजेनेसिस पार्शियल मोड। अब इसमें आप देखें, एज आई हैव टोल्ड यू, उसमें सबके अंदर जो है वो जो है हाइड्रोपिक हो रहा था या एडिमेटस हो रहा था। इसमें जो है सम आपको villi जो है वो नजर आ रहे होंगे, फाइब्रोटिक भी है, कुछ नॉर्मल भी नजर आ रहे होंगे, कुछ बिल्कुल फाइबर से फिल्ड हो गए। तो पार्शियल मोड में कुछ पार्ट जो है वो नॉर्मल होता है और कुछ जो है वो एडिमेटस या हाइपरप्लास्टिक होता है। तो ये डिफरेंस है पार्शियल और कंप्लीट मोड में हिस्टोलॉजिकली। अब ये देखें, इसमें आपको फीटस भी दिख रहा है और मोल्स भी दिख रहे हैं। तो उसके अंदर कोई फीटस प्रेजेंट नहीं होता कंप्लीट में, इसके अंदर जो है वो फीटस भी प्रेजेंट हो सकता है पार्शियल के अंदर, क्योंकि इसमें जो है नॉर्मल ओवम इज फर्टिलाइज्ड बाय टू स्पर्म। लेकिन ज्यादातर फीटस जो प्रेजेंट होगा उसके अंदर मैनी मैलफॉर्मेशन होगी, मैनी कंजेनाइटल एनोमलीज होगी, और ज्यादातर जो है वो इट इज मोस्टली डेड एट द टाइम ऑफ द when we remove the placenta, we remove the this, most of the time it is dead. Now the third one, after the non-invasive, the second variety of mold is the invasive. Invasive का दूसरा नाम है destructive mold या chorioadenoma destruens, grossly invasion of molar tissue into the uterine wall, which may be source of hemorrhage. इसमें क्या होगा, बहुत ज्यादा डीपली इन्वेड हो जाएगा, इन्वेड कर देगा एंडोमेट्रियम में, मायोमेट्रियम में, तो इसकी वजह से the chances of the hemorrhage, the chances of the bleeding is more. Rarely molar tissue may invade blood vessel and reach the lung. तो लेकिन ये जो इसको हम मेटास्टेसिस में कहेंगे, इसको हम कहेंगे कि it is the emboli of this mole reach to the lung when they invade the blood vessels of the myometrium. Microscopically, lesion is benign, as you know, and identical to the classic mole, but has potential for hemorrhage. Okay? They invade deeply, so chances of the hemorrhage is there. Always associated with persistent elevation of beta-hCG. As you know, in all the toxoplastic conditions, molar pregnancy, the beta-hCG level is raised as compared to the normal pregnancy. The level is more. So, mold, hereditary form mold divided into two types: invasive and non-invasive. Non-invasive is divided into two: partial and complete mold, और दूसरा है invasive है, जिसका other name है, another name of invasive is destructive mold, chorioadenoma destruens. Now the last condition of the trophoblast is the choriocarcinoma, is the tumor which arises from the placental epithelium. As I have told you, choriocarcinoma, another choriocarcinoma which arises from the ovary. And at that time, I have told you also that there is a placental or gestational choriocarcinoma. So this is the gestational choriocarcinoma. Gestational choriocarcinoma is highly malignant and widely metastasizing tumor of trophoblast. 60% of cases occur following hereditary form mode, 25% following spontaneous abortion, 20% after normal pregnancy, 5% develop in an ectopic pregnancy. और ज़्यादातर, as I have told you, the chances of choriocarcinoma is more in complete mode as compared to the partial mode. Choriocarcinoma is more common in Asia and Africa than United States and Europe. Most common complaint is vaginal bleeding following pregnancy. Occasionally, patient present with metastasis in brain or lung. Widespread and frequent hematogenous metastasis is present. कॉमन साइट्स जो मेटास्टेसिस के हैं वो लंग है, वेजाइना है, ब्रेन है, लिवर है, किडनी है. डायग्नोसिस, एज यू नो, ऑल द टोक्सोप्लास्टिक कंडीशंस आर detected by the beta-hCG level in plasma and urine. As I have told you, there may be a choriocarcinoma which is present in ovary. तो दोनों के दरमियान फर्क क्या है? Ovarian choriocarcinoma more aggressive as compared to the this gestational choriocarcinoma. और ये it arise from the placental epithelium, और वो जो है tumor arise from the ovarian tumor is arise from the pluripotent cell, pluripotent cell. और this carcinoma, choriocarcinoma, is chemosensitive as compared to the choriocarcinoma which is present in the ovary, which is not the chemosensitive and not respond to the chemotherapy. This choriocarcinoma is respond to the chemotherapy well. और दूसरा ये इसके अंदर डिफरेंट ये है, when we see this gestational choriocarcinoma, we detect the paternal antigen. लेकिन ovarian जो choriocarcinoma हो उसमें paternal antigen नजर नहीं आएगा. तो ये दो तीन differences है जो कि important है, which is the how we can differentiate between the choriocarcinoma of the ovary and the gestational choriocarcinoma. और दूसरा ये कि this choriocarcinoma contain hemorrhages and necrosis. So sometimes these are necros only we detect by the metastasis when these choriocarcinoma metastasize to the brain or lung. Secondaries are detected earlier as compared to the primary tumor. The chances of detecting this choriocarcinoma is more when we detect the secondary, and primary is not detected. Grossly, tumor appear as hemorrhagic, soft, fleshy mass, necrotic. Sometimes tumor may be small, often like a blood clot in the uterus. मैंने जैसे कि आपको बताया that told you hemorrhagic and necrotic और इसमें क्या होगा self destruction कर देगा necrosis ज़्यादा हो जाएगी तो इस वजह से sometimes tumor may be small बिल्कुल छोटा हो जाएगा like a blood clot in the uterus. लेकिन जब उसको एग्जामिनेशन किया जाएगा हिस्टोलॉजिकली डिटेक्ट किया जाएगा इट मे बी अ कोरियोकार्सिनोमा. Microscopically absence of identifiable villi as compared to मोलार से करेंगे तो उसमें villi नजर आती है इसमें कोई हमें villi नजर नहीं आए. Masses and columns of highly anaplastic and bizarre cytotrophoblast and syncytial trophoblast cell which are intermixed. दोनों मिक्स हो जाएंगे लेकिन कोई डिफरेंट हम उसको डिटेक्ट नहीं कर सकेंगे. Presence of hemorrhage and necrosis as I have told you. Invasion of underlying myometrium, blood vessels and lymphatics as I have told you. Gestational choriocarcinoma respond very well to the chemotherapy, as I told you. With hysterectomy and chemotherapy, cure rate is improved. 75% 5 year सर्वाइवल रेट यानी कि अगर कीमोथेरापी के साथ हिस्टेक्टोमी कर जाए तो क्योर जो है वो बहुत ज़्यादा है कंपेयर टू द ओवेरियन कोरियोकार्सिनोमा. इफेक्टिवनेस ऑफ ट्रीटमेंट इज मॉनिटर्ड बाय बीटा एचसीजी डिटरमिनेटर. बीटा एचसीजी लेवल जो है वो आहिस्ता आहिस्ता जो है वो decline with them. Slowly they decline. Then we know that our treatment is perfect. Death is generally due to the fatal hemorrhage in CNS or lung. Mostly the primary site is not dangerous as compared to their secondaries in the CNS or lung or the from pulmonary insufficiency. तो प्राइमरी ज्यादातर नेक्रोज होने की वजह से डिटेक्ट नहीं हो सकती तो हो पाती. Sometimes they may be detected, sometimes they may not be detected, but they are metastasizing the tumors and the secondaries there. When they reach to that site, they produce symptoms, and most of the time they are detected by their secondaries. Here you can see the picture of the choriocarcinoma. Soft, fleshy, white tumor है with a marked tendency to form a large, pale areas of ischemic necrosis, foci, cystic softening, and extensive hemorrhage. और यही necrosis की वजह से self destruction या self destroyed भी हो सकता है. Here you can see the picture of the microscopic histopathological picture of choriocarcinoma. Inactive endometrial gland है. Residual rectal is present. Now, what are the difference between these trophoblastic diseases? तो यहाँ पर हमने देखा है complete, partial choriocarcinoma. Karyotype, as I have told you, complete में 46XX और rarely 46XY होता है. Clinical finding diagnosis जो है वो मोल्स है. Vaginal bleeding जो है complete में marked bleeding होती है. Uterus size large है. HCG level जो है high है. HCG in tissues marked. Embryo gross appearance, as I have told you, complete में present ही नहीं होता है. Vesicles जो है वो large है, regular है, villi present है. Villous size uniform है. Hydropic villi, they all, as I have told you, trophoblastic proliferation diffuse all three: cytotrophoblast, intermediate trophoblast, and syncytial trophoblast. ATP are diffuse, blood vessels generally absent, and persistence after initial therapy 20% chances है. और behavior है ज़्यादातर, as I have told you, most of the time the chances of the development of choriocarcinoma is more incomplete as compared to the partial. Partial मोड जब ट्राइप्लॉइड होते हैं, ट्रिप्लॉइड होते हैं 69 XXY, 69 ट्रिपल एक्स या 92 भी हो सकते हैं टेट्राप्लॉइड. मिस एबॉर्शन हो सकता है इसमें. और दूसरा जो है वेजाइनल ब्लीडिंग माइल्ड है एज कम्पेयर टू द कंप्लीट मोड. यूट्रस साइज इसमें एज कम्पेयर टू द कंप्लीट मोड स्मॉल इन साइज. सीरम एचसीजी लेवल इसमें जो है वो लो होता है एज कम्पेयर टू द कंप्लीट मोड. एचसीजी इन टिश्यू इसमें जो है मार्क इसमें माइल्ड है. एम्ब्रियो इसमें प्रेजेंट होता है, मे बी प्रेजेंट एज कम्पेयर टू द कंप्लीट मोड. वेसिकल इसमें स्मॉल एंड इरेगुलर. विलाई दोनों में प्रेजेंट होता है. विलस साइज यूनिफॉर्म है. इसमें मैंने बताया था पार्शियल में कुछ नॉर्मल होते हैं, कुछ एबनॉर्मल होते हैं, कुछ फाइब्रोटिक भी होते हैं. हाइड्रोपिक विलाई उसके अंदर दे इन कंप्लीट मोड दे इन्वॉल्व ऑल इन दिस सम विलाई आर इन्वॉल्व. ट्रोफोब्लास्टिक प्रोलिफरेशन है, फोकल है, सिंसिटिव ट्रोफोब्लास्ट. ATPR इसमें मिनिमल है. ब्लड वेसल इन्वॉल्व प्रेजेंट है. और persistence after initial therapy 7% chances of developing the initial condition after the treatment. Behavior, choriocarcinoma almost never there. As I have told you, most of the chances of choriocarcinoma is complete mole as compared to the partial. Choriocarcinoma 46XY और very rare. Abortion हो सकता है, मोलार हो सकता है, टोपिक जो प्रीवियस कंडीशन हो सकती है, मार्क एबनॉर्मल हो सकता है, persistent high सीरम एचसीजी लेवल, लोकलाइज इंसेंसिटिव ट्रोफोब्लास्ट एचसीजी टिश्यू जो है प्रेजेंट होगा थोड़ा सा लोकलाइज, एम्ब्रियो नॉट प्रेजेंट है, वेसिकल्स नो वेसिकल्स, एज आई टोल्ड यू देयर इज नो वेसिकल, विलाई ऑलवेज एब्सेंट, और माइक्रोस्कोपिक में जो है वो कोई विलस प्रेजेंट ही नहीं है, हाइड्रोफिल विलाई भी प्रेजेंट नहीं है, और प्रोलिफरेशन जो है वो साइटोट्रोफोब्लास्ट और ट्रोफोब्लास्ट में होगी, एटीपीआर जो है मार्क कोरियोकार्सिनोमा में बहुत ज़्यादा एटीपी के हो गए, ब्लड वेसल प्रेजेंट एंड एबनॉर्मल, और क्योंकि मेटास्टेसाइज रैपिडली इज नॉट ट्रीटेड क्योंकि ये इन्वेड द मायोमेट्रियम एंड दे इन्वेड द ब्लड वेसल। बिहेवियर है क्या, सर्वाइवल रेट विद कीमोथेरेपी 70%, एज आई हैव टोल्ड यू the gestational choriocarcinoma is respond well with chemotherapy. तो सर्वाइवल रेट अगर कीमोथेरापी है की जाए तो 70% चांसेस है कि जो है पेशेंट सही है। Now our second part of this lecture is the fallopian tube. Fallopian tube, as you know, the important structure uh, for the pregnancy, important structure for the female, पेयर्ड स्ट्रक्चर है, दोनों साइड बोथ यूट्रस के दोनों साइड पे है, एक्सटेंडिंग फ्रॉम सुपीरियर एंगल ऑफ द यूट्रस to the region of the ovaries and running in the superior border of broad ligament forming mesosalpinx. Each tube is 7 to 14 centimeter long, divided into 4 parts. It is very much important to know the parts of the fallopian tube. Interstitial portion, which is present within the uterus. The part narrow asthenic portion, wider ampullary region. Ampullary region is wider, and it is the site where most of the time fertilization is take place. Funnel like distal infundibulum. Infundibulum जो कि ovaries के होस्ट है, ovaries के अंदर single life projection जाता है. Infundibulum is fringed by fimbriae, longest of which called fimbriae ovarica is attached to ovary. तो ये तीन पोर्शन हो गए, इंटरस्टिशियल पोर्शन है, नैरो एस्थेनिक पोर्शन है, वाइडर एम्पुलरी रीजन है, फनल लाइक डिस्टल इन्फंटिब्यूलम है जो कि ओवरीज के अंदर जा रहा होता है, सिंगल लाइफ प्रोजेक्शन प्रोड्यूस कर रहा होता है। हिस्टोलॉजिकल फीचर है, वॉल ऑफ ट्यूब है, 4 पोर्ट, सीरस है, फॉर्मिंग पेरिटोनियल कवरिंग है, सब सीरस है, फाइब्रोवास्कुलर टिश्यू है, मस्कुलर है, composed of longitudinal and circular stigma, tubal mucosa, having 3 types of cells, ciliated, columnar, dark, intercalated cells. Serosal covering may contain teeny nodular masses of mesothelial cell forming wall third cell vessel. Due to the, it is very much not so much important, but it is important to know the normal structure or the fallopian tube or the normal structure of any organ and somewhat histological features of any structure. Now, first of all, the inflammation. As you know, the pelvic inflammatory disease is most common cause of infertility in our areas, in developing countries, and it leads to the salpingitis. PID, pelvic inflammatory disease, is a clinical syndrome characterized by signs and symptoms of ascending infection beginning in vulva or vagina and spreading through the entire genitals. As you know, the unhygienic condition and there's a lack of awareness in our areas, so the chances of pelvic inflammatory disease is more in our areas as compared to the developed areas. PID में अगर following abortion, वही जो है कि उसके अंदर जो है वो सही जो है अगर क्लीन गाइडेंस ना रखी जाए तो following abortion the chances of PID is more after continuum of with use of intrauterine contraceptive device. जब वो होगा तो there are chances of more or from local intra-abdominal infection such as appendicitis with peritonitis. PID occurs as a ventrally transmitted infection caused by the chlamydia, trachomatis, and Neisseria gonorrhea. The most important organism which lead to this chlamydia, trachomatis, and Neisseria gonorrhea. Post-abortal and postpartum infections are caused by Staphylococcus, coliform bacteria, Clostridia, and pneumococci. Patients generally complain of lower abdominal pain, pelvic pain, which is bilateral, dysmenorrhea, menstrual abnormalities with fever and tachycardia. Chronic PIT may lead to the infertility and adhesion between the small intestine and pelvic wall. So it is a serious condition. The symptom is not so much painful, but it can lead to the infertility and can lead to the serious complication later. Grossly fallopian tubes are involved violently most of the time. Distal end is blocked by inflammatory exudate and lumina are dilated. Formation of lobulated tubeo-ovarian abscess involves tube, ovary, broad ligament, and chest part. When the uterus is involved, it involves the tube, ovary, broad ligament, adjacent part of the uterus. Microscopically processed begin with the acute salpingitis. Usually there is the acute salpingitis characterized by edema and intense acute inflammatory infiltrate of neutrophil involving tubal mucosa as well as wall of lumen is filled with purulent oxidant consisting of leukocyte and fluff of epithelial cells. Purulent process may extend to involve tube as well as ovary causing salpingitis and forming tubo-ovarian abscess. Escape of purulent exudate into peritoneal cavity produces pelvic peritonitis and pelvic abscess. When they are ascend from the vulva, vagina, cervix, involve the uterus, involves the both tubes, and then it can lead to the involvement of the peritoneal cavity and lead to the pelvic peritonitis and pelvic abscesses. Pyosalpinx, the presence of the pus in the fallopian tube is the distension of fallopian tube with pus due to occluded fimbrial end. You can fimbrial end to close a occluded end, though there may be a fallopian tube is distended with the pus. Pyosalpinx after resorption of purulent exudate is hydrosalpinx. जब पस जो है वो रिजॉर्ब हो जाएगी तो वो हाइड्रोसल्फेट्स में चेंज हो जाएगी जिसमें द ट्यूब इज द थिन वॉल डायलेटेड एंड फिल्ड विद क्लियर वाटर. एक्यूट साल्पिंजाइटिस में रिजॉल्व विद ट्रीटमेंट. अगर उसको सही तौर पे ट्रीट कर लिया जाए it can be resolved, but some cases pass into chronic salpingitis with infiltrate of polymorphs lymphocytes. As you know, lymphocyte plasma cells are the chronic inflammatory cells. So when if acute salpingitis is not treated, then it can lead to the chronic salpingitis, and it can lead to the involvement of the adjacent organ. It can involve the peritoneum. It can lead to the ectopic pregnancies. It can lead to the rupture of the fallopian tube. Now, the TB salpingitis, the tuberculous salpingitis. As you know, the tuberculosis is a common disease in our area. So the chances of the tuberculous salpingitis is more in our areas compared to the developed area. Tuberculous salpingitis is almost always secondary to focus as well. TB salpingitis कभी भी primary नहीं होती. ज़्यादातर most of the time it is secondary to the tuberculosis which is present in other part of the body. Tubercle bacilli reach the tube by hematogenous route, generally from ज़्यादातर most of the time it is secondary to the pulmonary tuberculosis. Occasionally from urinary tract or abdominal. ज़्यादातर most of the time TB salpingitis is secondary to the pulmonary tuberculosis. कभी कभार जो है most occasionally from urinary tract or abdominal cavity. Tubal tuberculosis is always present when there is a tuberculosis of other female genital organs, such as endometrium and Sadia. Incidence of tubal tuberculosis in developing countries is about 5% concomitant involvement of endometrium present in 80%. दोनों यानी कि involvement of endometrium और tubal जो है वो तकरीबन 80% cases में involved है. It affects more commonly young women in their reproductive life. Most common complaint is infertility. जब भी fallopian tube involved होगी, the chances of infertility is more. Grossly tube is dilated and contain purulent exudate, tubal peritoneum as well as peritoneum in general. It is studded with yellowish tubercle, TB के tubercle. Microscopical typical caseating granuloma and chronic inflammation are present in tuberculosis, vascularis, and mucosa. It involves all the layer of the fallopian tube, and it can lead to the involvement of the whole tube, and it can lead to the infertility. It can lead to the ectopic gestation. Now, the last topic is, or the most important topic is the ectopic tubal pregnancy. As you know, ectopic pregnancy can occur on other side, but the common side is the tube, fallopian tube. Implantation of a fertilized ovum into tubal pregnancy is the most common form of ectopic gestation. Several predisposing factors of ectopic tubal pregnancy are pelvic inflammatory disease, previous tubal surgery, use of IUCD यानी intrauterine contraceptive device, and congenital abnormalities या congenital anomalies of the female genital tract. When there is any unfavorable condition for a fertilized ovum for the implantation, then they implant any other site in the female genital tract or any other site outside the genital tract. Then the condition or the atmosphere is not favorable due to the infection, due to the surgery, due to the presence of IUCD, due to the anomalies of the female genital tract. This fertilized ovum can implant at other site, and this is called as ectopic pregnancy. Most frequent site of ectopic pregnancy is the fallopian tube और मोस्टली द एम्पुलरी पेशेंट. एम्पुलरी पेशेंट मैंने जैसे कि आपको बताया कि वो वाइडर एरिया है. The chances of tubal pregnancy is more in ampullary portion of the fallopian tube as compared to the other part of the fallopian tube. और ये जैसे कि मैंने ये लिखा and less common is the interstitial. The interstitial portion is the portion of the tube inside the uterus. उसमें less chances होते हैं और सबसे ज्यादा चांसेस होते हैं एम्पुलरी पोर्शन में, जो कि वाइडर पोर्शन है. एक्टोपिक ट्यूबल प्रेगनेंसी कैन लीड टू द रप्चर एंड इंट्रापेरिटोनियल. जब ये फर्टिलाइज्ड ओवम जो है वो इंक्रीज साइज होगा और तो इट कैन लीड टू रप्चर और हेमरेज हो सकता है. Now you can see the uterus, bowel, clotted hemorrhage, and fallopian tube. और ये देखें size of the tube is और ये है 5 feet कहते हैं ectopic pregnancy. यहाँ पर ना सिर्फ they may produce hemorrhage and it can lead to the hemorrhage and it can lead to the rupture of the fallopian tube and it can lead to the shock, and it is very dangerous condition when ectopic pregnancy is ruptured anywhere in the female genital tract and any other part. It can lead to the excessive hemorrhage and it can lead to the shock. Another picture, large tubal pregnancy, where you can see along with the uterus, and you can compare the size of the tube. So this is the another picture of the tubal pregnancy. The outcome of the ectopic pregnancy most of the time is the rupture of the organ which implanted. There may be a rupture of this part of where this ectopic pregnancy is taking place. There may be a hemorrhage. There may be a shock. So ectopic pregnancy in all sites are dangerous. And it is how we can detect ectopic pregnancy. We can detect by the β-hCG. When β-hCG level is raised according to the pregnancy, and we perform the ultrasound, but we cannot see the implanted embryo or book. So we can suspect there is an ectopic pregnancy outside the uterus. So most important both investigations is β-hCG level, and the second is the ultrasound of the female genital tract. So it is today we have completed the female genital tract. Inshallah, on the next time we started with the bone and joints. Thank you.